Hi, everyone. On behalf of the European Society of Ophthalmology Young Ophthalmologist Division, I would like to welcome everyone to our SOE-YO webinar on pediatrics and AI in ophthalmology. We have made this webinar possible in collaboration with the AAO, American Academy of Ophthalmology, YO, International Representative Simon Fung, and we're really happy to have a speaker from the USA in each session. So before we begin, I want to run you through some housekeeping items. So to start with audience questions, we really encourage you to ask a lot of questions. You do so by clicking on the Q&A button in the bottom of the Zoom call. And we'll be looking at all the questions you're sending in and trying to answer them all in the end of each session, where we have a Q&A session together with all the speakers of each session. But sometimes we can't manage, we don't have the time to answer all the questions. So if you have any answers left after the webinar, please send us an email to soewebinars@soevision.org. And then we'll try and answer them in a separate document, which will be assessed via the SOE webinar. Also, really important, you can upvote the questions by clicking the thumbs up button in the Q&A window. So the questions you think are really good, they will be upvoted and we can answer them to begin with. Also important, the webinar is being recorded and it will be available later on the SOE website and also placed on the SOE YouTube channel. So now finally, I would like to just talk you through the running order for today. So each webinar, each talk will be presented consecutively. So to begin with, we have the first session, Pediatrics and Ophthalmology. We have 3 talks that will be followed by discussion with the 3 initial speakers. After that, we have the session of AI in ophthalmology with 3 talks that also will be followed by a final discussion with those 3 speakers. So if you'd like to ask questions again, please just put the questions in the Q&A section on Zoom. And yeah, I'm happy to start to introduce the first speaker. So for our ophthalmology pediatrics session, our first speaker is David Ramirez, who will discuss the exciting topic 2 eyes, 4 eyes, reviewing the pediatric eye exam and when to prescribe glasses. So David is an attending ophthalmologist at the Lurie Children's Hospital and an assistant professor of ophthalmology at Northwestern University. He's also a member of the AAO-YO committee, and he has a specific interest in using big data to advocate for programmatic and policy change for marginalized youth. And he's also interested in evaluating the socioeconomic impact of on the delivery and outcomes of pediatric eye care. So I'm really excited to hear this talk, David. Thank you.
Hello, everyone. My name is David Ramirez. I am a pediatric ophthalmologist at Lurie Children's Hospital in Chicago in the US, and I will be talking to you today about just a few pediatric pearls. Examining children can often be hard, especially when they are really reluctant to see you or be examined by you. So maybe another good name for this talk is how to examine a child who has no interest in being examined. So we'll just walk through a couple of pearls about examining children, working with children, and then I'll finish up with just some quick tips for the exam. So basic rules of the pediatric eye exam. Number 1, be optimistic. Number 2, you are the one who is in control. Number 3, always show what you're going to do with the child. Number 4, always talk directly to the child, not just to the parents. Number 5, how to manage tantrums. We'll walk through all of these in detail. And just during this process, Before you're about to go into the room with the kid, let all that stress just melt away and remind yourself that this is going to be a playful, fun visit. Again, be optimistic. It's going to go great. Remind yourself that it takes patience, persistence, and playfulness. And if you remember those three things, the visit will go great. So rule number one, be optimistic and believe that it can happen for you. Believe that you can examine the child. This attitude rubs off on the kids. If you seem like you're going for certain parts of the exam and you're trusting them to be able to complete them, they will trust you, even if it's just kind of a feeling. That kind of starts the rapport with the kids. And then really use positive reinforcement as a tool. Negative reinforcement, not so great at building a rapport, not so great for setting this kid up to do well at future eye exam visits. So really positive reinforcement only. And again, believe that it's going to happen for you, and then you will be able to do it. That moves us into rule number two. You are in control. Do not let the exam get away from you. You are the one who guides what we're doing. If now is not the time to be running around the room or trying to open the door and run away from their parents, you are the one who is in control and able to guide the exam. Similarly, with parents, you are the one who is guiding the exam, not the family. So please make sure to just set those boundaries early on and then be confident about what you're doing. This goes back to being optimistic, being confident, being persistent. If you're checking a pressure and they're really kind of wiggling their head around, ask for help. Distract the child. We'll go through some of these techniques, and ultimately you will be able to do it. I promise you. Distraction is essential, and really in any kind of pediatric visit, the point is to be silly. That's what children like, right? So your ego just kind of goes out the door with that. So if you need to sing, if you need to make funny noises, if you need to cluck with your mouth, if you need to throw things across the room, anything you can do to help you and put you at an advantage to distract these kids is going to take you really far. Rule number three, demonstrate exactly what you're going to do. So before you approach the child with an unknown instrument, right, like a slit lamp, an indirect, a lens, anything like that, they're going to be wary if they haven't seen anything like that before. So talk to them. When they're at the slit lamp, tell them they get to ride the motorcycle, tell them you're going to play a game and see if they can find Barney in the light. When you're doing the indirect exam, tell them you have a special light to help you look for cookies inside their eyes or see what's inside their head, or their butterflies flying around in there. Is there candy? Kids love that kind of stuff. And then when you approach them with these instruments, like I said, tell them what it is. And everything is a game, right? With kids, everything can be creative. So the pen light is a birthday candle, and you can have them blow on it. The slit lamp is a TV where you're looking for Barney. It's a video game they're playing with their handles on the sides. The indirect, you're checking to see whether they're a superhero or not. These are all just really quick and easy ways to get kids curious and interested in participating in the exam. Rule number four, talk to the child. Don't forget the child is your patient. Not only will children notice this, but parents will notice this. So if you're just talking to the parents the entire time, they'll notice. If you're just talking to the parents the entire time, the children will notice, and they will get distracted and start getting up from the exam chair and moving around. So remember, engage the child, be authentic, be genuine, ask them questions depending on what age they are. They are your friend here. Also know that you may have a limited window to examine these kids before their patience runs out. Chances are they've already been examined by the technician and their vision has already been checked, their pressure has already been checked, and you're coming in to either recheck or look at the alignment or whatever. They only have so much focus. Remember when you were 5, if you were asked to sit still in a chair for an hour or 2 hours, would you have been able to do it? No, I mean, I know I wouldn't have. So this is something that you just have to keep in the back of your mind. Games, focused exam, confidence, move everything forward. And then rule number 5, tantrums. Obviously, they happen. Sometimes it's just part of being a child. They'll just have a total meltdown when you come at them with any kind of lens, even if it's at the very beginning. So you have 2 options here. You can either ignore it and just proceed with the exam as necessary, or you can acknowledge it. You can try to distract them with toys, with noises, singing, talking to them. And I always say bribery is not only tolerable, but essential. You have to have distractions for these kids. If you can sit through this exam, you'll get a lollipop afterwards, or you can tell them, I have a bunch of superhero stickers outside and I can give you 3 stickers if you can sit really still. And it works. If nothing else, you can ask the parents for help. One thing that I like to do if a kid is having a total meltdown is asking if they have a favorite YouTube video or something that the parents can kind of hold right behind you, right at your ear as you're trying to either do retinoscopy, look at them with an indirect or what have you. And parents know their kids the best, right? So anything that they can do or suggest is helpful, but it's up to you to bring that up and guide them. So now I just want to go through some rapid fire tips. So fixation, toys are your best friend. A good rule is that a new toy gets a new look. So if you're using the same toy for all different kinds of exam maneuvers and it seems like they're not really being engaged, get out a new toy. These toys on the right-hand side of the screen here just go on your finger and you can kind of wiggle them around and make the child follow the toy with your finger, have them look. You can ask them questions about the toy. How many eyes does Elmo have? What color is his nose? Is he wearing a bow tie? All of those things help keep kids engaged in the exam. And then just in terms of special testing, so there are certain techniques. When you're checking suppression with Worth 4-dot, just asking them to touch all the lights they see. This works really well even in young kids who may not be verbal yet. And obviously, if they touch all 4 dots, that kind of tells you what's going on. Stereo, checking stereo, always important to block out all the other distractions because if you just show them the plate, they're not going to react like older children will. They may not look at exactly what you're wanting them to look at. So really kind of blocking out, in this example, everything but the animal on the line A is going to help the child focus. And then asking which animal is fuzzy, which animal's popping out, can you push the animal back down into its home? Those are all questions that help kids understand this part. The same thing with the circles, push the button down. Kids are really great with that. And then for color plates, tracing is always a good technique. Trace the lines that you see. Can you trace the picture that you see? And they're usually able to do it. For neurovisual fields, you're really looking for fixation. Look at my nose, or you can put a sticker on your nose and say, what do you see here? And then you just kind of gradually wiggle a toy and see if they look at it or if they initiate a saccade towards it. And that implies that they're able to see in their peripheral vision. And you test all 4 quadrants. Here I'm doing it monocularly, but in kids who don't like having things over their face, of course, you can do it binocularly as a quick and dirty. And then for the slit lamp exam, so believe it or not, most kids can use a slit lamp, no matter what age. And so here, a good technique is see this metal plate right over here. This can be removed, and I'll show you why that's important. So you want to position the child in the parent's lap, turn their legs a little bit to the side to make room for the slit lamp. Have them hold on to the handlebars, ride the motorcycle, ride a bike, drive the car, whatever you need to do to engage them. And then you'll have an assistant, either your technician or one of the 2 parents or other parents, and you're going to have them help you guide the head if the kid isn't able to really position in the slit lamp, kind of push them forward, stabilize their chin, and then if they keep trying to get away, giving them a bear hug to try to get your looks. So here you can see that technique. One hand is keeping the head in the right position. One hand is underneath the chin, kind of keeping the head in the right position while you're able to do whatever you need to do. And again, believe it or not, even babies, infants, you can examine in the slit lamp. Usually it's helpful to have someone behind you just kind of distracting them, but they're totally able to do it. For tonometry, a good technique when using the eye care, which is what we're using here, checking your eye color. Looks like your eyes are purple. Do you see? Let me check that out. Have you ever seen that your eyes are purple? Oh, looks like they're green now. Oh, looks like they're red now. All different techniques to use. And then in terms of drops, obviously, this is probably a lot of your experience with children and drops. A lot of kids don't like it. So what I've found is trying to talk to them about what's going to happen before the drops is essential. And this kind of really enables them to feel like they have control over the exam and that you're not just kind of doing things to them, which is what creates a lot of anxiety in the first place. Tell them what's going to happen. We're going to go swimming together. We're going to splash some water at each other. Or you can say, I'm going to put some Barbie makeup on you or give you a superhero mask. And then take requests. If they're really upset and really not letting you do it, before you kind of pry their lids open and just go, muscle through it, see if they can close their eyes and you can drop it in the corner and they can blink it in. See if you can tell them, we're just going to get your lashes wet, and work with them through this. Indirect, when you put that hat on, every single kid is going to look at you like, what in the world is that? What are you doing? Why are you holding this thing up to my face? So I always like to say, I'm checking for cookies inside the eye. I'm looking for butterflies inside your eye. And they'll usually hold for that. And then just to finish up, so in general, just tips for glasses, because I promised that I would talk about that. So once you're done with the exam, once you have your measurements, obviously you have to decide what to do with the glasses. So these are just some quick tips for prescribing glasses. Esotropic patients, you want to give the full plus to allow them to relax some of their near triad accommodative convergence, and see if that helps with an accommodative component. Non-esotropic patients who have amblyopia, what I like to do is just prescribe glasses first before starting something like patching, although some people do give glasses and patch on the first. But if there's no esotropia and you're giving plus, then in general, we'd like to cut plus because we want to encourage the kids to wear the glasses, and reducing that kind of visual blurring with cut plus helps. Esotropic patients who have amblyopia, you give full plus and then can move to patching, similar just for esotropic patients with no amblyopia. And then for exotropic patients with hyperopia, you can try to observe without, see if their control improves over time because they're wearing a natural minus if they're hyperopic. And then for exotropic myopic patients, myopic corrections can help with control and with any kind of amblyopia. So trust me, you can do it. There have been so many kids who have been referred to me who were, there was some concern we'd have to do an exam under anesthesia because they were so difficult to examine in clinic. And while sometimes that is the case, that is rare. Kids are able to do most things that adults can do, but you just have to make sure that you set yourself up for success. Be confident, be patient, be persistent, and be playful, and you will succeed. Thank you.
Thank you for the interesting presentation. Our next speaker is Trine Moldrup Jacobsen from Denmark. Her presentation is about myopia pandemic, how to prevent. We are ready to listen.
Hi, everyone. Well, I'm Trine Moldrup Jacobsen. I'm from Denmark, and I'm here to present myopia pandemic, how to prevent it. I have no financial disclosures, so I would like to touch upon the prevalence of myopia, the risk factors of developing myopia, sight-threatening complications, preventing the pandemic. Can we even do that? Whom should we treat, and what are the treatment options? So the prevalence of myopia varies greatly around the world, and the highest incidence is in Southeast Asia, and the highest prevalence is in Southeast Asia. So what are the risk factors for myopia? Well, we know that the genes play a role, but they cannot explain the huge increase we have seen in the prevalence within the last decades. We know that the degree of education and extended near work time are associated with higher prevalence of myopia. And then screen use is under a lot of suspicion for increasing the prevalence even further, but we really don't have the data yet to conclude anything. What we do know is that outdoor exposure is the best we can do to prevent myopia. So we need to get our kids outdoors to play. So why is it a problem that people are becoming myopic? Well, that's because of the sight-threatening complications to myopia. And we have pathologic myopia, which consists of lager cracks, chorioretinal atrophy, myopic CNV, and staphyloma. And then we also have associated risks like retinal detachment. We have an increased risk of glaucoma, and we have early onset cataract. A European study evaluated the risk of visual impairment by age and actual length, and they defined visual impairment as best corrected visual acuity of less than 0.5 at a Snellen visual acuity chart. So this is actually the driving license limit that they defined as this. And what they found was that, and that is shown in this figure, we have on the x-axis age and on the y-axis the cumulative risk in percentages. And so they put the actual length into different categorical variables. And what we see here is that the lowest risk is actually in people who had 24 to 26 millimeters of actual length. And in the late 70s, they had the lowest risk of visual impairment. However, when you jump to the higher groups, here you have the group with an actual length of 26 to 28 millimeters. And in the late 70s, they had a risk of almost 30% of visual impairment. The group with actual lengths of 28 to 30 millimeters had a risk of almost 50%. And if you had an actual length on or above 30 millimeters, the risk was almost 90%. So the length of the eye is a risk factor. And to me, it does make sense to treat myopia so that we decrease the actual length elongation, so that we can reduce the risk, so we can maybe put some of these patients into a lower risk category. But what about preventing the pandemic? Can we do that? Well, first of all, we need to ask the question, is it a problem to be myopic in a modern world? And I don't know the answer to that. Is pathologic myopia a problem? Yes, it really is, because it decreases the visual acuity enormous. But then who is at risk of pathologic myopia? Well, we know that the risk increases with the degree of myopia. So again, to treat myopia and reduce the actual length, in my opinion, that makes sense. So whom should we treat? Well, in a Danish setting where I'm at, I think that we should treat myopic children, and we should treat the ones who are at risk of becoming highly myopic and who has an ongoing progression, because myopia stabilizes with age. And it varies when it stabilizes. So we need to make sure that these kids are still progressing, because the modalities that we use, they can reduce the progression, but if there's no progression, there's nothing to treat. So in order to do as I said, we need to make a risk assessment, and this can be done in various ways. There is a group that developed growth charts on European children, and what we have here is the age on the x-axis and the actual length on the y-axis, and we have two different curves because we have one for boys and one for girls. So by plotting the age and the actual length, we can make a risk assessment. What is the risk of this individual becoming highly myopic? This can also be done by the calculator by Brian Vision Institute. And this QR code, if you scan it, it will take you straight to the website. So just giving you a minute to scan the code. So in order to determine if there is an ongoing progression, we need an observation period. And we can evaluate if there is progression by measuring the actual length, or we can use cyclopedic autorefraction. And once we have determined if this child is at risk of becoming highly myopic and it also has an ongoing progression, we can start to talk to the family about treatment options. And right now there are multiple different modalities to choose from. We have the peripheral defocus spectacle lenses. We have atropine eye drops, autokeratology lenses, which are used during sleep, and we have the daytime soft defocus contact lenses. We actually, in my opinion, don't have a really good meta-analysis comparing these treatment options as for now, so I made kind of my own little schedule. And what we have here is the modality. Then we have the contrast in actual length progression during 2 years between the active treatment and a control group. Then we have a reduction in percentage, which we're not going to use, and then the number of studies. And what you see is there are not many studies. So to go through them, I have 3 points for these slides, and I'm going to come back to that. But we have the stellets, which are spectacle lenslets, and also the MyoSmart, and they have shown really good results. Then we have a meta-analysis on autokeratology lenses. So this includes more studies, and it seems that no matter the brand, they work pretty efficiently. Then we have the MySight contact lenses, which are soft defocus lenses, and we have atropine 0.05%. And I could only find 2 studies with a duration of 2 years, and they have a very different treatment efficacy. So there are still a lot of questions as to which is the best treatment. But in my opinion, as the literature is right now, I would say that these 5 options here would be my choice of recommendation. I think that the atropine 0.01% seems to have a very low efficacy, so I would not suggest using that. And my third point is that putting plus in the periphery does not equal good myopia control. So be careful. Don't just use a lens for presbyopia or something, because this meta-analysis down here showed that if you just take any kind of novel design, the efficacy is actually pretty bad. So what about treatment goal? Well, as a rule of thumb, according to the risks that we looked at earlier, I would say try to avoid actual lengths of more than 26.5 millimeters, or cyclopedic spherical equivalents of less than -6 diopters. And then depending on the age of the child and the eye length, then you need to try to set yearly goals for the treatment efficacy. And then you can intensify the treatments by combining the modalities, or you can increase the atropine dosage, or both. So the conclusions on my talk today is that high myopia increases the risk of sight-threatening complications. We need to get our kids outdoors in order to prevent them from becoming myopic in the first place. And when they are myopic, whom do we need to treat? Well, do a risk assessment, talk to the parents, show them this is the risk for this individual child, and then it's much easier to say to the parents, well, I don't think we need this. Your kid is 16, it's very low myopic. Or if it's a very young child, already highly myopic, saying we need to do this because otherwise the risk is just too big. But we also need to know if there's an ongoing progression. And then which modality to choose. I think it's the child's preference, and use the 5 that I mentioned before. And then otherwise the child and the parents can decide which modality fits their family the best.
Thank you very much, Trine, for this wonderful talk. There will be time for question at the end of the next talk, which is a talk by Aldo Wacke. He is going to talk about the approach to vertical strabismus. So Aldo is actually a national representative for Italy with SOE, and he did an international pediatric ophthalmology and strabismus fellowship at Wills Eye Hospital, and is now an associate professor and leader of the strabology, pediatric ophthalmology, and ocular genetics department at the University of Genova Ophthalmology Clinic. So really excited to hear about your talk, Aldo.
Hello, everyone. It's really a pleasure to participate in this webinar organized by the SOE Young Ophthalmologist Group. Thank you, of course, for the invitation. The topic of my presentation will be approach to vertical strabismus. I do think this is very interesting topic because learn some tips to have a correct diagnosis is essential before treatment, of course, especially in vertical strabismus. We can start with this patient, 61 years old male with binocular vertical diplopia, prism glasses that did not relieve double vision, and brain MRI that was normal. The refraction show a small amount of hyperopia and the vision was perfect. Here, the ocular motility examination, we have a hypertropia on the right eye, primary position, then increase to the left gaze, and with the right head tilt. So, the 3-step test in this case can help us to have a diagnosis. The first question to answer is which eye is hyperdeviated in primary position. And in this case is the right eye. So the paretic muscle must to be either one of the depressor of the right eye or one of the elevators of the left eye. So we can remove all the other muscles. Then the second question is, does the hypertropia increase in the right gaze or in the left gaze? In this patient, the hypertropia increased in the left gaze. Therefore, the paretic muscle must be either one of the muscle whose primary action is elevating the left eye on the left gaze, or one of the muscle whose primary action is depressing the right eye in the left gaze. So we can remove muscle that cannot be implicated. The last question is, does the hypertropia increase in the right head tilt or in the left head tilt? In our patient, the hypertropia is greater with the right tilt. then the right superior oblique is implicated in the palsy. So why we have an increase of the hypertropia with the head tilt on the same side? In this case, the right side, because when the head is tilted to the right, the left eye need to turn outward, need to carry out a cyclotorsion, and the right eye need to turn inward, so need to carry out an encyclotorsion. But if the muscle that have to create encyclotorsion is paretic, prevail the superior rectus that raise the eye. So the diagnosis is in this case seems to be pretty easy. Is a right foreigner palsy. We know that the palsy can be congenital or acquired. The latter, we know that is usually a result of closed trauma, or less commonly, vascular problem or brain tumors. How we can recognize a congenital versus acquired foreigner palsy? It's important to examine childhood photos of the patient to check pre-existing compensatory head tilt. However, we know that manifestation of congenital palsy sometimes become apparent only later in life. Then it's very important to evaluate for the presence of large vertical fusional amplitude, and we know that normal range is about 2-3 prisma diopter, which support in this case a diagnosis of congenital superior oblique palsy. Then it's important to evaluate for any associated neurological disorder that suggest an acquired condition, and also remember to look for facial asymmetry that result from a long-standing head tilt with a mid-facial hemi-hypoplasia on the side opposite to the palsy muscles. These slides, I think that is very important. So an concomitant deviation is characterized by the presence of muscle sequelae. In fact, when we have a palsy of a muscle, such as in this case, the right superior oblique palsy, we have an overaction of his yoke muscle. The yoke muscle is the contralateral synergist. From the onset of the palsy, so immediately, for area low. Then we have an overaction of the ipsilateral antagonist after a period of time, usually a few months, due to the Sherrington law. And then we have inhibition of the contralateral antagonist due to the Ehring and Sherrington law. And remember that this is true in palsy of any muscles. These muscle sequelae can spread the comitants, and this can often make diagnosis of the initial muscle palsy sometimes very difficult. But let's go back to our patient. So the diagnosis was a right foreigner palsy. However, if we had measured the deviation in all the position of gaze, we'd have noticed that there is a reversal hypertropia in a field of gaze, a V-pattern isotropia, and a subjective torsion exceeding 10 degrees. So cannot be a palsy of just one oblique muscles. In this case, the correct diagnosis is bilateral foreigner palsy. In fact, the bilateral superior oblique palsy is characterized by any combination of these features listed in these slides. So superior oblique palsy after closed trauma, subjective complaining of torsion, objective torsion exceeding 10 degrees, reversal hypertrophy in any field of gaze, V-pattern isotropia, and a chin down head posture. In a vertical strabismus, it's very important to evaluate both the objective and the subjective torsion. In fact, the subjective torsion tells us the symptoms needing treatment, and we can measure it using, for example, the double Maddox rod test. Only some tips for that. So if the red line is below to the white line, is the right hypertropia, if of course the red lens is on the right eye. If the line do not appear parallel, there is a cyclotorsion. Then the patient is asked to align the two lines so that they are parallel to each other and the floor by rotating the dials of the trial frame, and in this way we can check the amount of torsion. Can happen that the patient tend to localize the torsion to the eye with the red lenses. So to be sure, we can repeat the evaluation with the red lens on each eye, so the right eye and the left eye. We can also use the Bagolini lenses to measure the subjective torsion. This is the least dissociative test that produces a streak of light parallel with the axis of the lenses as opposite of Maddox test. So in other words, to get a 180 degrees line, we need to orientate the Maddox at 90 and the Bagolini lens at 180. The objective torsion is important because we identify the eye with the problem. Normally, the fovea lie between an imaginary line level with the bottom of the optic nerve and the second line at the junction of the lower 1/3 and the upper 2/3 of the disc. If the fovea is below the lower line, the eye is extorted. And if it's above the upper line, the eye is intort. But keep in mind that the image seems that we see with the indirect ophthalmoscope is inverted. Some important information. Objective torsion is the same regardless of which eye is used for fixation. Only after a long occlusion, at least 45 minutes, of the affected eye, there is often an increase in objective torsion in the not affected eye. And then remember that we can have objective torsion without have subjective torsion if patient did not have a bifoveal fusion. A question arises. So is the three-step always a reliable test? The answer is no. In fact, remember that the three-step test is based on the assumption that there is a palsy of one vertical muscles. Look at this picture, a patient with the left hypertropia that increase to the right and with the left head tilt. So the diagnosis is left foreigner palsy. But if we perform version of the eye, we can observe a restriction of the right inferior rectus. The patient was fixing with a restricted eye. There are a lot of other reasons of error in the three-step test, as reported in this paper by Dr. Kushner. Our patient, for example, had a multiple muscles involvement. Look at this picture, a right hyper that increase to the left and with the left head tilt. So the diagnosis is compatible with the left superior rectus palsy, but the correct diagnosis is a DVD of the right eye. In fact, as you can see, a DVD, in this case of the right eye, often, not always, about in 70% of the case, increase with the head tilt on the same side. Skew deviation is a vertical strabismus caused by a supranuclear lesion in the posterior fossa, and is another reason of error in three-step test. Two clinical features are very important to me, as reported by Dr. Wong, a vertical deviation that decreased by more than 50% from the upright to supine position suggests a skew deviation. And the second clinical feature is the presence of an encyclotorsion of the hypertrophic eye. In fact, in the superior oblique palsy, there is an excyclotorsion of the hypertrophic eye. So when we use the three-step test, keep in mind to check this additional step. Patient is fixed with the involved eye. We need to assess the torsion, subjective and objective. So we need to check the pattern of the strabismus that help us the diagnosis. Patient has a DVD, any previous surgery, any finding that suggests skew deviation or myasthenia, and of course, collect a correct clinical history. Why is so important check if the patient is fixing with the involved eye? Here a patient with a superior oblique palsy, a right superior oblique palsy, fixing with the uninvolved eye. We can see all the clinical features we described. So there is hypertropia in primary position. You see that when the gaze is up and to the left, the right inferior oblique shows marked overaction. The action of the left superior rectus is normal. When gaze is down and left, the right eye do not fully move into the field of gaze of the superior oblique. But look at the same patient with the paretic eye fixing. As we can see, we have a left hypotropia in primary position. When gaze is up and to the left superior rectus is underacting because the right inferior oblique need less than normal innervation to elevate the right eye because it's an antagonist of the right superior oblique, and the right superior oblique is palsied. This is the concept of the inhibitional palsy of the contralateral antagonist. And this may confuse our diagnosis because it seems that there is a left superior rectus palsy. But if we cover with an occluder the right eye, the left eye can go up normally. A very last concept, is the over elevation in adduction a pathognomonic sign of only superior oblique palsy? We should remember, and the answer is no. So we should remember that when we call inferior oblique overaction, so this term is already a diagnosis. Better to describe this pattern as over elevation in adduction. In fact, look how many causes of over elevation in adduction. We have pseudo inferior oblique overaction, a DVD, a upshoot in Duane syndrome, anti-elevation syndrome of the opposite eye after a surgical anteriorization of the inferior oblique, craniofacial syndrome, contralateral inferior rectal restriction, or primary inferior oblique overaction. So, thank you for your attention. Unfortunately, there is no time to talk about surgery, but hopefully we can discuss on it in another webinar. If you have any question, please feel free to email me at my email address, aldo.vagge, @gmail.com. Thank you again.
Welcome back. Yeah, thank you, Aldo. Unfortunately, Aldo's not present with us for the discussion part, but David and Trina, if you'll please join us. So now we follow up where everyone can ask questions in the Q&A section. So please feel free to post your questions. You can also post questions to Aldo, and we'll try and forward them to him via email if you didn't get his email on his last slide here. So Lana, you wanted to start with the first question we have?
Yes, there are some interesting questions. The first one was, how can I diagnose staphylomas on fundus exam? I think this question is to Dr. David Ramirez. Can you please answer this question, Dr. David?
Yes, hello everyone. Nice to meet you. I'm David. I work at Children's Hospital, Lurie Children's Hospital in Chicago. Great to be here. Thanks for having me. Trina, I think, would love to hear what you have to say about this as well. But in terms of diagnosing staphylomas, clinically, if you don't have anything like an A scan or ultrasound, even sometimes you can see these staphylomas. Usually what I look at are just any signs of myopia. So that would mean kind of pigmentary changes around the nerve and or macula, straightened vessels coming off of the nerve. Obviously, you can use your refraction as an indicator if there's high myopia and you suspect any kind of staphylomas to begin with, and then looking for any other signs of pathologic myopia like lac or cracks or things like that, although I haven't seen that a lot in young kids.
Yes, well, I may add that sometimes on the fundus you can see like a ring where the staphylomas kind of starts, or the periphery of it. And then also I think that using an OCT can be very useful, and you can kind of see how the back is just way too steep. But I don't have much experience in that either yet. So, and I think sometimes it can be difficult, but it usually occurs with age. So it's not in the young patients that we see it. And so they'll have a stabilized myopia for the whole adulthood of their lives, and then all of a sudden they start to become myopic again, increasingly myopic, and then so that's a great clue also that there may be a staphyloma there.
Thank you so much for the answer. Dear Kirsten, can you?
Yeah, thank you, Trina. Yeah, we have another question for you, Trina, I think. It says that ophthalmologists in Eastern Europe often insist on the effectiveness of atropine. And could it be that there is more research on the orthokeratology lenses only because it's a more lucrative field than the eye drops? And maybe Trina, you can elaborate.
Well, I will say that there are many studies on atropine. The thing about atropine is that we know that the higher the dose, the better the efficacy, but there's also a rebound effect. And I think that in those low dose atropine studies, it's been kind of late on that we started using or doing studies on low dose atropine. And now it is pretty much considered to be unethical to make long durations of myopia control studies where you have a control group. So most studies now are designed with a control group that has, for only 1 year max, and then they're crossed over to an active treatment because scientists feel that it's unethical. And that's why we only have few studies with a 2-year follow-up period. So I think that's the case more than it's about profits.
There is some more question, I guess. There's a question. There's a question to with Trina again. Dear Trina, have you used atropine in my sight lenses?
Maybe it's together, like in a combination.
Mm-hmm.
I think that's the question. And no, we haven't used that specifically, but I wouldn't hesitate if that was, if I needed to do that in a child that used my sight lenses and then we needed a better myopia control, then I would definitely add 1 drop of atropine after removing the lens at night. Then the child could put in a drop of atropine. Yes.
Thank you.
We also have a question for David, I think. It's
Mhm.
in case of amblyopia and not esotropia, why do you prefer not to give full correction? Doesn't it need full stimulation, especially in anisotropic amblyopia? Yeah.
Yeah, it's a great question and something I think intimidates a lot of people when they're prescribing glasses. So there's the concept of full plus and cutting plus. And so when you're doing the cycloplegic refraction for kids, if they have any amount of esotropia, I always say give full plus for the reasons that I mentioned in the talk. But in the setting of no strabismus, the reason that you don't want to give full plus is because there's really no accommodative drive that the plus is going to relax, and you're really giving it for a different reason. So you're giving it for a refractive reason. And so giving full plus, especially in anisotropic amblyopia, where presumably one eye is normal or good or whatever, and the other eye is weak, if you were to give full plus to a child, then they would hate those glasses and would not want to wear them because their good eye would be blurry. So remember, when you're doing cycloplegic refraction and you uncover maybe a +1 in the good eye and then like a +5, say, in the other eye, once their cycloplegia wears off, they're going to accommodate through that +1 in the better eye. And so if you blur their better eye, then they're going to hate the glasses and not want to wear them. So especially in anisotropic amblyopia, again, with no strabismus, I always cut plus by about 1.5, 1, something like that. And it's really to encourage them to wear the glasses for the other eye. Great question.
I have one question, if it's possible. When you have exotropic patient, exotropia and plus refraction, how do you correct in this case?
Yeah, so that's the thing where you can say that. So exotropic patients who have plus, so sometimes for exotropia, you can give minus therapy, right? So you can over minus patients, and by giving patients minus, then you can stimulate their drive to converge. So that's what over minusing does. And so taking that idea and applying it here, if you're exotropic and when you're cyclopleged, you have a hyperopic correction. In theory, when you're not cyclopleged, you're naturally minusing yourself. And so you can actually, depending on how big it is, of course, but in small deviations, you can watch those patients because they're in what's called natural minus, because they need a hyperopic correction and you're not giving it to them. So it's as if you're putting minus lenses over their eyes. So you can follow those patients usually, and of course, managing amblyopia if it develops with patching or something like that, or if you're concerned about a refractive problem, then you can give the prescription and see how they do. But those patients, I feel a little bit more comfortable following if they can manage it.
Thank you. Thank you so much.
Thank you. I think we have time for one last question, and it's for Trina. It's myopia is a risk for glaucoma development, and if atropine treatment has a risk of rising the IOP.
Studies haven't found that. There was a Danish study that I know that measured IOP. It was in 0.01% atropine in one group, and then they had a group with 0.5% atropine as kind of a kickoff, and then going down to 0.01%, and it didn't show any IOP rise.
Thank you very much for all your questions, and thank you very much to the speakers for your participation. And again, if there are any further questions, we'll try and answer them afterwards and put them online.
Thank you so much. Let's start another session.
So The next session we'll start now is AI in ophthalmology. And I'd like to present our first speaker, Nathalie Eriksson, to talk on the role of AI in patient information. So AI is a fast-growing, exciting new play in medicine, and I'm really excited to hear the next couple of talks. Again, if you have any questions, please put them in the Q&A answer while we are talking, and we'll try and answer all of them at the end of the next 3 talks.
So my name is Nathalie, and I'm currently a resident in ophthalmology at Rigshospitalet Glostrup in Denmark. And I have been invited here to talk about the role of AI in patients' information. So the next 10 minutes or so, I will go through this agenda, and then there will be some time afterwards for questions. So first, I will talk about why patient information is important. And of course, there are some ethical and legal obligations to make sure that our patients are well informed about their disease or their treatment or any kinds of procedures they may have to go through. And this is to make sure that they make informed healthcare decisions, and it improves adherence to treatment and provides better communication between the healthcare professional and the patient, and preventing medical errors. Also, it enhances patient satisfaction and optimized resource use. For example, when a patient knows when to contact the hospital or when not to. However, if there is language barriers, then nothing is gained in terms of providing information on health and disease management. So we may set out some good initiatives to create patient information, but often we realize that none of these initiatives seem relevant for ethnic minorities who are not able to speak the official language. And this is where AI might be of use. Generative artificial intelligence is a new technology able to generate new data, such as text and images, videos. And videos are an excellent format for conveying information on eye health, as you can benefit from illustrations, video angling, highlighting, and audio. And HeyGen is a generative AI model which is publicly available as a software, so anyone can use it. It provides, among other things, it provides video translation with a natural voice clone, similar speaking style, and synchronized speech with lip movements. And based on this, this group of physicians you can see here set out to investigate how AI could be used in patient information. And we conducted an exploratory study of the capability of the generative AI model, HeyGen. We used one of our patient information videos on how to use eye drops, which originally is in Danish. And then we translated it using HeyGen. So we translated the video into 6 different languages with different linguistic distance from Danish. So we translated into English, German, Polish, French, Turkish, and Arabic. And then the videos also underwent forward-backward translation, where the translated videos were retranslated into Danish. And you can see a clip of it here. And before I show you, the first clip is a clip from the original video, which is in Danish. And then there comes another clip when it's translated into English, and then the translation into Arabic is the last one. So you can see it here if it's going to play.
Når vi har flasken her, når du skal dryppe med den, så kan du placere din pegefinger i bunden af flasken og holde på siden her, fordi så kan du nemmere styre dråberne. Du kan styre, hvor mange der kommer ud, og det er faktisk rimelig svært kun at trykke på siden af flasken. Den er lidt hård at trykke på, så det er meget nemmere at trykke i bunden af flasken. When we have the bottle here, when you need to drip with it, you can place your index finger at the bottom of the bottle and hold it on the side here, because then you can more easily control the drops. You can control the quantity, and it's quite challenging to press on the bottle side. It is a little difficult to press, so it is much easier to press at the bottom of the bottle. عند حمل الزجاجة هنا عندما تحتاج للتنقيط يمكن وضع إصبعيك في قاع الزجاجة والاحتفاظ بالجانب هنا لتسهيل التحكم في القطرات. تحكم في عدد الأشخاص اللي يخرجون. صعب الضغط على الزجاجة. صعبة الضغط عليها قليلا. من الأسهل الضغط في أسفل الزجاجة.
Yes, so that was a clip. But across all videos, the voice was recognizable, and it was a clone of the original individual, and the lip movements synchronized with the voice, as you could also see here. However, the intonation in the translated videos appeared less varied than in the original one. And these videos were then evaluated by ophthalmologists with high proficiency in Danish and each of the 6 languages we translated to. And they evaluated the accuracy of the translations, and you can see some of the inaccuracies here. For example, I've highlighted this one, but for example, here in the original text, original video, the nurse says when you apply eye drops. And in the German translation, she says when you kill your eye, which is not the correct translation. And also, yeah, in here the last one here, you can see that number of drops in the original video translates to number of persons in Arabic. So there are some inaccuracies. So to evaluate the quality of the machine translations more objectively, we used the bilingual evaluation understudy algorithm, also called BLUR. And a value of 0 here means that the machine translated output has no overlap with the reference translation, so it's a low quality translation. And a value of 1 means that it has a perfect overlap with the reference translation, so high quality. And you rarely see a score of 1, but the closer to 1, the better. And looking at the results, you can see that highly related languages were translated with a higher accuracy than remotely related languages and languages with no recognizable relationship. For example, English here gets the best score, and Turkish the worst score. And also inaccuracies in the forward translation were repeated in the backward translation. That's also one thing we found out. And also there were some differences in the voice tone compared to the original video. But despite these inaccuracies and differences and the relatively low blur score in general, the overall message remained understandable across all languages. And this is presumably also because they were presented in a specific context and with the video showing the procedure. But of course, there's some limitations to the study. We only considered 1 video and only a limited number of languages. Also, our assessment is partly based on subjective evaluation by ophthalmologists, and our target group are actually patients. So we don't actually know if it's understandable to patients, and our evaluators could have knowledge bias as they already know what to expect of the video content. Then also we use this blur score or this algorithm as an objective measure, but blur measures only similarities between words and their alignment in sentences. Of course you can have translations that are accurate without using the exact same words, or with the same words but in a different organization in the same sentence. But with that said, we found that generative AI makes it easy and affordable to translate important patient information. Sorry. And video-based illustration and information is especially important in eye care, making information more accessible to those in our society that may need it the most.
Thank you for the interesting talk. Our next speaker is Grayson Armstrong from US. His talk is about artificial intelligence in research. Is AI ready to write research articles, reviews, and clinical trials?
Hello, everyone. My name is Grayson Armstrong. I'm over at Massachusetts Eye and Ear in Boston, Massachusetts, and I'm excited to talk to you about AI and research. Is AI ready to write research articles, reviews, and clinical trials? Here are my disclosures, none of which are relevant to this talk. And today we're going to talk about review of the use cases of generative AI and large language models in ophthalmology, and we'll discuss the benefits and pitfalls of the use of LLMs in research and academic pursuits. Large language models, as a review, are artificial neural networks capable of general-purpose language generation and other natural language processing tasks, such as ChatGPT. The most common use case is text generation, which could take the form of drafting emails, preparing presentations, or writing research abstracts. And as a disclosure, I did not use ChatGPT to create this presentation for you today. LLMs use statistics to determine which words or phrases work well together during generative AI tasks. For example, if you put in the phrase, "The best thing about AI is its ability to," the LLM will then select the next best word based on statistics. It might choose the word learn, or it might use predict, make, understand, do. In fact, there's a whole list of words that, based on statistics, might be the next best word in that sentence. And then the LLM will use that word and iteratively plug in the next best word in a sentence and can create sentences, paragraphs, and entire manuscripts based on this methodology. The most common LLM to date is ChatGPT, whose current model is ChatGPT 4.0. It only took 5 days for 1 million users to download and employ ChatGPT. Other models include Copilot, Gemini, Llama, Lambda, Claude, Bert and Ernie, Bart, Vit, Dolly. There's a lot out there, but ChatGPT is certainly well and away the leader. An example of ChatGPT's use is if I plug in the phrase, "Describe angle closure glaucoma in the style of Snoop Dogg in 4 sentences." As you can see, in the time it took me to describe to you the prompt, it was able to generate the following text. And unfortunately for all of us, I won't be trying to attempt a Snoop Dogg impersonation, but I'll let you read it for yourself. So how have LLMs been employed in ophthalmology? LLMs are great at generating text-based responses to queries, and research has inquired whether this is useful to our field. One of these studies is a comparison of ophthalmologists and large language models to chatbot responses to online patient eye care questions. It found that in this cross-sectional study of responses to 200 eye care questions from an online advice forum, ratings of the quality of chatbot and human answers were not significantly different regarding the inclusion of incorrect information, the likelihood of harm caused, extent of harm, or deviation from ophthalmology standard of care. Another looked at the accuracy and reliability of chatbot responses to physician questions. And it found that in a cross-sectional study of 33 physicians across 17 medical subspecialties who generated 284 medical questions, chatbot generated predominantly accurate information in response to these diverse medical queries. If you look at the use of ChatGPT and other chatbots to address the ophthalmic knowledge and ophthalmic board exams, ChatGPT has been found to answer approximately half of questions correctly from OptoQuestions free trial. In addition, the fact it was used on the German board exam, and the fact that ChatGPT 4.0 could have passed the specialist exam in 12 out of 15 topics was found to be remarkable. ChatGPT also achieved a 91% success rate on the EBO examination in France, demonstrating a high level of competency in ophthalmic knowledge and application. However, it's not all cheery. One study found that LLMs, in particular ChatGPT 4.0 and Bing Chat, can perform similarly with human respondents answering questions from basic science and clinical science self-assessment program from the AAO. However, the frequency of hallucinations and non-logical reasoning suggests room for improvement. What's a hallucination, you ask? We'll get to that in just a second. Unfortunately, ChatGPT on its own has been found in one study to provide incomplete, incorrect, and potentially harmful information about common ophthalmic conditions when asked by patients, defined as the recommendations of invasive procedures or other interventions with potential for adverse sequelae, which are not supported by the AAO. And these downsides and these drawbacks are just why we're talking about the risks and benefits of this today. So, should LLMs be applied to research? Well, it already has. If you do a bibliometric analysis of ChatGPT in medicine, you'll find that in 2023 alone, the first year of its use across all systems, ChatGPT was published in 786 medicine-related articles, and it was used across many diverse specialties, including internal medicine, surgery, radiology, health system services, and others. The American Academy of Ophthalmology's Ophthalmology Journal then published an article that talked about generative AI's use in the field of ophthalmology. And it has a few specific benefits that were highlighted, especially in terms of research. First, it can improve the quality of text and writing. It can rewrite and reformat, for example, abstract preparation. It can be used for summarization and synthesis of articles. You can use this to create initial drafts of perspective pieces or original articles. And it can be used for coding assistance, for data management and debugging of code. However, there are some major drawbacks, the first of which is hallucinations, which is made up peer-reviewed scientific articles or other content that does not actually exist and is factually inaccurate. So, this has been shown in research. Here we see a study where prompts were given to ChatGPT with little data, and it was surprising to note that it could still generate good abstracts with fake data from unknown sources. For example, when asked to construct a medical abstract on the topic of aflibercept versus ranibizumab for wet AMD, several data points like demographics, pre- and post-treatment visual acuity, p-values, and adverse events were constructed by ChatGPT on its own. When confronted as to where it got this data from, ChatGPT's reply was the response I generated was a hypothetical example based on a common research approach and is available medical literature and the topic, but unfortunately it was all inaccurate. So, this is evidence that ChatGPT, when not provided with a complete data set, tends to plagiarize from unknown sources in medical literature, which is a dangerous pitfall. Without equally good software to pick up AI-generated text, the editors and reviewers would seriously fall short in detecting this plagiarism, and this could seriously impact the trust factor in which science stands. Another study found that AI models were used to generate completely fabricated scientific articles, but although the papers looked sophisticated and seemingly flawless, expert readers may identify semantic inaccuracies and errors upon closer inspection. So, additional drawbacks include response generation, which supports assumptions built into the inputs, which may not be accurate assumptions in the first place. LLMs are also potentially trained on outdated data, which may predate current and updated clinical guidelines and recommendations. It may mirror biases of the training data, and if that data has biases inputted into it, then unfortunately the outputs will too. Data security concerns do exist over inputted data, as programs like ChatGPT retain user-provided information and keep that for future iterations of the program. So, let's imagine you're comfortable with all of this, and you want to submit your article. Well, at that point, programs like JAMA do have some guidance for authors, peer reviewers, and editors. For example, if you submit to JAMA and JAMA Network Open, you will be asked the question, did you use AI, a large language model, machine learning, or similar technologies to create or assist with the creation or editing of any of the content in your submission? And for those that answer yes, you'll be asked to answer two more questions. You'll be asked to provide a description of the AI-generated content, the name of the model used, the version and extension number, and the manufacturer of that AI model. You'll also be asked to confirm that you take responsibility personally for the integrity of the content generated by these tools. For peer reviewers, it's notable that entering any part of a manuscript or abstract or text into a chatbot, large language model, or a similar tool is a violation of confidentiality agreement. But if an AI-based tool is used in a way that doesn't violate confidentiality, the tool must be disclosed as well as the description of the content created. So, in summary, I like to think of ChatGPT and LLMs as a semi-competent and efficient intern that knows nothing about ophthalmology and needs all of his work double-checked because he may be prone to stretching the truth. In summary again, there is an article titled Best Practices for Using AI as an Author, Peer Reviewer, or Editor. And for authors specifically, they break down all of the recommendations into 3 major categories: accountability, transparency, and confidentiality. In terms of accountability, we must be accountable for the content of AI-generated comments submitted in the manuscript, and you cannot list generative AI as a co-author. In terms of transparency, if generative AI was a part of the study design, it must be included appropriately in the methodological detail in the methods section of a manuscript. And if generative AI was used to generate manuscript content, then clearly state this in the acknowledgement section and how and where generative AI was used. If no generative AI was used, consider stating this in the cover letter. Regarding confidentiality, authors who use generative AI do so at their own risk. And you must understand the terms of use of any generative AI to understand how the content of prompts that you use may be reused by the generative AI and the company that created it. So, in closing, LLMs are amazing new tools that stand to benefit the field of ophthalmology and ophthalmic research. Major benefits of LLMs include improved efficiency in content generation, including manuscript and abstract draft preparation. Authors for this foreseeable future will be responsible for the content of the manuscripts, regardless of how much assistance is provided by the LLM applications. And caution should be used in employing LLMs for research purposes, as major risks exist, including hallucinations and erroneous content, data security concerns, and risk of bias. That said, I'd like to thank you for your time, and I will be taking questions.
Thank you, Garrison, for this interesting talk, and we'll be happy to answer all of the audience's questions at the end of our next talk. And I would like to introduce Ivan Potapenko, who will discuss ophthalmology disrupted, embracing the AI. So Ivan is a junior vitreoretinal surgery consultant at Rigshospitalet in Copenhagen. And he has a PhD that focused on the application of artificial intelligence in ophthalmology. And he is passionate about technological innovations in the medical field. So I'm really excited to introduce you.
My name is Ivan Potapenko, and I am very happy to be able to present this presentation for you today. I would like to start by looking at the following slide. This shows the AMD patients in active treatment in our department for the past 15 years and a decade into the future. As you can see, the number of patients is increasing, and I think this is the same trend we can see for many types of patients and many subspecialties. So for cataracts, for vitrectomies, for diabetic patients, and so on. And this is kind of the perfect storm where we used to think that AI would come in and solve many of our problems and remove some of the pressure from the healthcare system is under right now. If we look at the number of AI publications, they are increasing, and they have been doing so for the past few years. Right now, we are at a rate of around 1,000 articles with AI in ophthalmology per year. However, this AI revolution has still not reached the clinic, and the question is why. There has been written quite a lot about why this has not happened, and this is one of the articles I recently read about the subject, and the authors attempt to give 5 reasons why AI has not been widely implemented in clinical ophthalmology yet. And I would actually disagree a little bit with these arguments, and I will tell you why. So the first argument is validity. I don't think this really is the issue. We know that, for example, with anti-VEGF treatment, injections perform much better in a study setting than they do in a clinical setting, but that does not prevent us from using them. In the medical school, we learn that if you're given a drug and you use it on your patients, but we're not told how to use the AI, and I think that's a larger issue than validity itself. Then generalizability, I think this is a somewhat of a moot point. If you have bad data, either it is a clinical study or it is an AI study, garbage in, garbage out. It doesn't matter if it's AI or non-AI. The third point, interpretability, has been discussed quite a lot. People say AI is a black box. Again, I would somewhat argue with that, because you also use advanced statistics. You get a p-value and you're happy, and you really don't always understand what's going on, the mathematics, the statistics behind it. The same is with AI. There is nothing different about it. Longevity, that has more to do with the IT part of things. You update your systems. You need to update perhaps your models and the way you run them. This is an IT department issue. I don't think it's very relevant. Finally, liability, and now we're kind of getting a little bit more towards the crux of the problem here. So I have added some of my own points. I think expectation is a problem, because we expect AI to perform perfectly. It's an intelligence, right? It's in the name, and all the hype surrounding it and in the press really kind of builds up to this superhuman performance. And it's really just a test. If you get an area under the curve of 92%, you say, oh, that's poor performance. But in reality, it is very, very good. It's just a test. We have some legislative challenges. We do not have a legal framework of how to use AI in medicine, and I think that's a big problem. People always say that there are some ethical concerns using AI. And that is partially correct. I will not argue with that, but I also think that there is a cultural and psychological part of this that is a problem for us, because we're not used to interacting with AI. So you can get mad at a doctor for making a mistake. You can forgive a doctor for making a mistake. You can't really get mad at AI. You cannot get mad at or forgive AI. In the same way, you cannot get angry at your prostate antigen test coming out high, right? So perhaps there is not that much difference from what we already know. And the final point is the workflow. I think the workflows that we're used to, that we practice under, are built for hospitals in the late 20th century. And not the 21st century, where AI is around. So that is the reason why we have so much trouble seeing where AI fits. It is because the workflows are not designed for AI. So where do you fit autonomous AI? Where do you fit models that improve themselves? Where do you fit patients that use AI at home? It's really difficult for us to see, and that's because we have been taught to practice differently. So let us take a look at a couple of workflows that could be implemented in a future world where AI is used more in the clinics. So this is a study we did a couple of years back. We wanted to see whether we could build an AI that would autonomously follow and treat AMD patients. So, and just a side note, talking about the interpretability, this is the output, a mock-up of our AI system. It uses plain English to explain why it has made a certain decision and what kind of treatment the patient should receive. And also, it knows when it does not want to make an autonomous decision, and sends it over to a second opinion with a human ophthalmologist. We tested this system prospectively on a pilot cohort of patients, and it actually performed quite well. It was non-inferior to our human colleagues in the department for the decisions that it made autonomously. And this is, of course, all hypothetical and theoretical and on the computer. But if this was to be implemented in our clinic at our hospital, actually we would reduce our patient list by 60%. So we would have 60% fewer follow-ups at our hospital, which is a huge number. Again, suffice to say this will not happen because of legal and ethical issues, but if it could happen, it would tremendously impact the way we see patient and how much pressure there is on our department. And of course, if you start thinking about even perhaps further into the future, you can think about the Scanly device, like home OCT monitoring. You have a new patient, and instead of telling them to come in every month or whatever, you give them this OCT machine they can have at home, and they just come in for the injections when the machine tells them to. I was fortunate enough to be a co-author on a paper about use of Amsler grid, which we did not find very useful for screening for wet AMD, and we did actually something rather rather bold. We recommended patients to go to the ophthalmologist instead. This caused a little bit of an uproar because this is a huge extra burden. You know, if all the elderly patients will go every year to see their ophthalmologist, we won't be seeing any other patients. But again, this is last century thinking. You know the photo booths from your shopping mall down the street. We can have OCT booths. You come in, you put your head in, look at the green cross, OCT of one eye, OCT of the other eye, smiley face, see you another year, don't need to go to the ophthalmologist. Or a message which says that you need to go to the ophthalmologist, there might be something wrong with your retina. So this is, again, completely new workflow, screening the patients and taking them some of the consultations out of the current equation and reducing the pressure on the public health system. So finally, we need to think creatively and redesign our workflows to exploit AI as well as we can. Legally, well, we have the new EU AI Act. All of these applications are classified as high risk, so we need to see how it plays out. It'll be very interesting. It is an ethical issue, but it is as much a cultural issue, I think, the usage of AI for treating patients. But I think in any case, we as doctors own ourselves to use it, to learn it, to familiarize ourselves with it, and advocate it to our patients. The elderly patients, if we don't advocate it, they won't use it. The younger patients, well, they are already using it probably, so we are behind. Thank you very much for your attention.
Thank you for the interesting presentations. Dear Kirsten, are you here?
Yeah, I'm here.
Let's start Q&A. Do you have any questions?
So yeah, we'll like to ask us three speakers, Ivan, Garrison, and Natalie, back into the discussion part. And please, everyone in the audience, feel free to put in your questions to the speakers. So meanwhile, I can start with one of my questions. Ivan, maybe you can answer this one. So can AI repeat and even reinforce inequality in healthcare? More in the means of, for example, if we're doing a lot of for example, in pictures, we're doing a lot of pictures on white male men, and then this OCT won't be able to find any differences on the fundus pictures in other ethnicities, for example.
Well, that is the question of data and generalizability, of course. So it is, you know, if you train your model on a data set that does not contain a representative sample of what patients you will be screening later, then it won't be as good. I'm quite sure that it will perform somewhat okay-ish, but it is much better to train on the same broad spectrum of patients that you are expecting to have later in the clinics. This goes on to reinforce what Grayson told in his presentation with the mirroring of the biases. So if you have a bias in the data that you train on, the same bias will come through in the final model. Yeah.
Thank you. Yeah, maybe Grayson, you have some. Yeah.
Sorry.
Yeah, I was thinking that, one of the ways to combat that is to never make assumptions that it will work in all populations, because while the data may seemingly work well, you don't want to assume that. And so after the model has been created, it's usually wise to employ it in your own population and test it to make sure it's performing accurately before you employ it at wide scale. And so that's kind of more the implementation side. It's funny, most of what we see with AI right now is really in the research phase in medicine. It's a little too early to say that there are many wide-scale models that have already been employed in the clinics. But when that day comes, it is important to make sure that locally, within our own patient populations and our own backyards, we do need to make sure that the models are detecting the diseases, they're screening appropriately with our own patients before we deploy it.
Thank you very much. Yeah, really good answers. So if we don't have any more questions from the audience, I might have a question to Natalie. So, for example, you talk a lot about using AI for patient information in pre-recorded settings, but what about live patient information if you're in the situation? And how could you, for example, deal with data protection in these situations?
So the biggest problem with the translation is actually the translation right now. So it's not translated completely accurate. So live translations might be a bit of a problem right now. And the reason why the video I showed you was like a good example of using AI without all these challenges we just heard about is because there was no patient information that couldn't be could be used by the program afterwards. So that is one of the big challenges if we use it like when we have a patient, because then it would be more like patient data and patient samples, and that might not be ethical to put into some kind of AI translation. So that right now that's not maybe not such a good idea, but so that's why we only discussed the pre-program. But I don't know, maybe in the future it would be something we could use, especially if the software programs have some kind of like you can click that they can't share or use this information that you're putting into it.
Thank you very much. Yeah.
I have some questions. We have some questions in our Q&A. Do you have any experience with the open source ARETF Foundation model development by Ukla and Moorfields? I think Dr. Ivan Potapenko wants to answer. Could you please?
Sure. I don't have any direct or personal experience with them, but I think the general thought with these models is that you train them on a great data set that is usually called the pre-training phase. And then you, when you have this so-called foundation model, then you specifically train them on a set of specific images. It can be AMD, it can be whatever you want them to do. But that last training phase is kind of specialized for the task you want them to do. The thought is that this will improve the generalizability of the model and will improve the performance. I think the basic thought process behind this is, of course, sound. That's the same thing that we did when we did the study that I mentioned in my talk. It's a great way of going forward. I think it also feeds into this self-improvement of models. When you deploy the model on site, you kind of feed its performance back to it and say, well, you know, these patients you did good, but then these patients you made some mistakes. The problem is this is all well and good, and it works. It can work quite well. The problem is, how do you license such a model? How do you approve, FDA approve or CE approve a model that changes, a model that does not have a fixed error rate? It's very difficult. We don't have the legal framework to do that as of now.
Thank you very much, Ivan. Yeah.
Thank you so much.
We have another question from the panel. So the next question is, AI is developing very quickly, and will this affect the labor market for doctors? Should health ministries promote or, on the contrary, hinder the implementation of artificial intelligence? I think everyone's free to give their opinion.
I think there are more than enough patients that will need our care for years to come, and I don't think that we need to worry about it taking our jobs. I think in many ways that it will assist and augment our capabilities, and it's great for many of the aspects of care that physicians may not need to be a part of. For example, screening for diseases like glaucoma, diabetic retinopathy, AMD. That can happen outside of our clinics, and perhaps we can spend our time with patients that truly need the care and try to cut down on our clinic visits for unnecessary visits. Maybe not truly unnecessary, but patients that are otherwise healthy, like Ivan was talking about. And I do think there are opportunities for AI to advance to a point where it could help assist us in the clinic as well. It hasn't gotten there just yet. Many of the ways I've seen it coming to play in medicine faster are the non-clinical use cases, like scheduling efficiency for our clinics and ORs, trying to help with billing and coding, things on the back end that can make our lives easier, but will perhaps not necessarily take our jobs away. It'll just make us more efficient as doctors. And in terms of ministries shutting it down versus promoting it, I think right now it's okay for them to take an actively neutral but engaged approach, I would say. You don't want to necessarily shut it down because there's a lot of promise and there's going to be a lot of advances, and it's very quick. You don't want to necessarily promote it too early, so you need to be cautious in its implementation. And so it is important for people like on our side, the FDA, for you guys, CE and others, to make sure that you do have appropriate guardrails in place and regulations to guide the implementation of this technology to make sure it's going the way it's supposed to go.
Thank you so much. We have one more question. What are some ways that we can decrease hallucinations with LLMs? And can we review the data that an AI was trained on to see if it's up to date with current clinical guidelines? What do you think about that?
I'd be curious what others think too. I know that for specifically models like ChatGPT, you can have a closed model where you take the foundation of ChatGPT, which is a foundation model, and you take medical data, perhaps subspecialty specific like ophthalmology, and train it using that data. It becomes very smart and much more knowledgeable on ophthalmology science. You can use it for PubMed, for example, and there are LLMs out there that do that. There's always going to be a risk that if you have it outsourced to a company, they have no incentive to show you the data that was trained on. And in fact, right now, the most recent version of ChatGPT, we don't really have any details on how many, what the sources were and how much data was used. But that is considered, I guess, a trade secret, so they don't have to do so. But that's also a risk. And you want to make sure that if you are doing any work with LLMs, you don't put any patient identifiers in the data because it might hold on to that and could be used down the road.
Thank you so much. If I have time, I have one question, short. Can AI pre-diagnose some eye diseases? What do you think?
what do you mean by pre-diagnosing?
I found some articles in cardiology or in other directions where artificial intelligence sometimes can pre-diagnose some, for example, heart strokes or any kind of diseases. Do you think in ophthalmology can AI diagnose some, pre-diagnose some diseases?
Well, there is the Alzheimer prediction study, the ALZI, and there is also for now it's I think 5 years back when Google showed that you can predict the blood pressure of a patient along with smoking status and so on. So you can gather quite a lot of information from the fundus images in those cases. I think it is the question is rather not necessarily what you can pre-diagnose, because I think you can pre-diagnose quite a lot of things. I think the question is how do you use the answer that you get, because it is not always clear how these things will work out in the clinical, in the broader sense of in diagnosing those conditions. I mean, do you screen the whole population for Alzheimer? Do you, what about the false positives and so on and so forth? So I think it is still a question of how these would be applied in the clinical sense of things. But it is, of course, very interesting and finding and very important as well that some of those diseases can be somehow traced from the fundus images.
Thank you very much. Ivan, thank you very much for your last answer. And I'm sad that we don't have time for more now. Thank you so much to Natalie, Grayson, and Ivan for speaking at this webinar. Really interesting and looking into the future. Really exciting. So as I said in the beginning, today's webinar has been recorded and it will be available on the SOE website shortly. Again, please, if you have any further questions, don't hesitate to email us and we'll see if we can answer this. Yeah, so now important for everyone, don't log off yet. There will be a short survey at the end of this webinar, so in a second. And please take time to complete the survey. Thank you so much for your time today to everyone. Have a good night.
Thank you, dear Kirsten.
Thank you, Lana.